Hello and welcome. With me is Dr. Gagandeep Kang from the Translational Health Science Technical Institute of India. Dr. Kang, hello and welcome to CNBC TV 18, and many thanks for joining us here on this show. First up, in your assessment, Dr. Kang, where do you think India stands as far as the coronavirus outbreak is concerned? ICMR says that we are still in the local transmission stage and we are not doing a testing on community level. But if you look at certain other states, particularly like that of Kerala, and we see their revised guidelines for testing, it certainly shows that we may have moved to community transmission. What in your assessment is the status? We are at community transmission or not?
I think without availability of testing data, it's very difficult to know what is and is not happening. I think that community transmission in India is likely very feasible to have happened. And if we test more, we will be able to find the extent of that. So in terms of the approach that we've taken so far, we've only done risk-based testing travelers and their contacts. That is never 100%. So it is good to think about some levels of community testing as a backup to inform you whether community transmission is happening or not. In the absence of any approaches that allow us to look at communities and whether there are infections going on, it's very hard to say where exactly India is on the epidemic curve. We do know that once transmission starts locally, things start moving very rapidly in terms of numbers of cases and particularly severe cases coming into hospitals. If we look at the countries that have controlled transmission and the ones that have not, the difference is in the testing, the ability to make wide testing available as quickly and widely as possible.
Well, Dr. Kang, if you say that we would have moved into a community transmission and it's quite inevitable in a country like that of India, what would be the scope of this transmission that we are talking about? Will it be restricted to the regions and the places and maybe the family and friend circle of the reported tested cases, or will it be beyond that?
In the absence of any level of testing, the only thing that you can go by is indirect signals. So if you look at evidence from New York, when they didn't have enough testing, what they looked at is what were the influenza-like illnesses? Did it look like a normal flu season or not? And what they are seeing is that flu season numbers should be coming down, but you can analyze the data to show that actually what's happening is that COVID-19 is filling the space that, where flu should have decreased, it's not decreasing. We don't have that kind of syndromic surveillance. If we are to look at whether community transmission is happening or not, there's two ways to do it. One way is to look at testing people and finding out whether people who do not have a travel history and do not have a history of contact are infected or not. The other approach is to follow syndromic findings and see whether the patterns this year are different from other years. So in New York, they've tracked the influenza surveillance patterns, looked at admissions and visits for respiratory infections, and shown that the levels that they are seeing are greater than are expected for influenza alone. So that would allow you to estimate what proportion of respiratory infections with fevers that come in that fit a sort of influenza-like illness case definition could be COVID-19. In the absence of such data in India on a countrywide scale or by state, it's very difficult for us to use that approach to estimate whether or not there is community transmission. So essentially, if we want to know whether there is community transmission or not, we have to test.
Well, you spoke about the influenza surveillance. In fact, even in India, we are using that. ICMR is using the influenza surveillance network under the Integrated Disease Surveillance Program to be testing people with influenza-like symptoms. But my question is that enough to be testing as far as community is concerned? What more needs to be done?
It is absolutely a step in the right direction. The symptoms of flu and the symptoms of COVID-19 overlap so much that it is very difficult at an individual patient level to tell the difference between the two. So using the influenza surveillance network is a good way to go. But unfortunately, the influenza surveillance network is not representative of the whole country. The locations where the network is located or the laboratories in the network are located, don't really have the kind of distribution that would tell us that this represents a good picture for the entire country. It's a great start, but the numbers are limited and it's not representative. So we should be thinking now, what is it that we do beyond the influenza surveillance network?
Right. Right. Ma'am, statistically, if we want to have an assessment, how do you think this community transmission would have happened, let's say for the 125 reported positive COVID-19 patients that we have, statistically, how many times more would the community transmission have happened?
So this is a little difficult to say. I can speculate, but until we have more data, it is just speculation. If you look at other countries that have good contact tracing, testing, tracing activities, then they have been able to control infections with a lot more than 120 infections coming in. But in our case, we know that the testing and the tracing of contacts has not been perfect, which makes me think that we really need to check on community transmission and whether that is happening or not. Again, I would emphasize that this is to inform better decision making. The bulk of patients who get infected are not going to be the ones who will get really, really sick. 80% do well. We are looking at doing this so that we protect the most vulnerable in our population, and that is people who are older and people who have comorbidities. Disease is spread by younger people, people who have a lot of social mixing, people who are professionals, who go to work, who travel. So even though they are not going to get the severe disease, they are the ones who are spreading the disease. And our responsibility is to the most vulnerable in our populations.
Well, if we talk of some of the initiatives and steps that the government has taken in the last 2 weeks to kind of arrest this medical and health emergency, is by closing the borders to certain countries. We are expanding that list. Yesterday itself, we added 4 more countries, including UK, where we've banned travel of people from those countries into India. We are also expanding, the compulsory quarantining of people coming from certain countries. Yesterday, we added 4 more countries onto that list. How feasible and helpful will this be in a situation like this? And secondly, the quality of screening at the airport is still a question in terms of the criteria that is being used to screen patients traveling from outside. Your assessment on that?
So I think when someone doesn't have symptoms, what can you rely on? You can look at a travel history and say you've come from a place that has a lot of disease and therefore you need to be quarantined or followed up very, very rigorously. So in that sense, this is the right kind of thing to do. Does closing borders help? Every little bit that you do that allows for people not to mix with each other is a good step. Is that step the going to completely control spread of infection? No, it's not, because we know that people can shed before they are symptomatic. There is a small proportion that is also asymptomatic infections. That's what makes this particular infection very difficult to control transmission. And what seems to work best is using every approach that we have available to increase or increase separation between people, restrict movement of people, restrict gatherings, restrict travel. These are all helpful steps. None of them is really perfect, because as long as you have some people coming in contact with others, transmission will happen. Remember, we are not trying to eradicate this infection from the world. What we are trying to do is to slow transmission down. A lot of people are talking about flattening the curve, and the curve, flattening the curve does not mean that you will have fewer cases. It just means that you will have fewer infected people at any given point in time. So we are spreading transmission instead of completely stopping it. If you did stop transmission right now, what would happen would be essentially, when you restricted all these measures, you might get a second wave where people who had not been exposed previously would now come up in large numbers. So what we need to do is to see how much do we stretch transmission out. And as I said, every action that separates people from each other will decrease transmission.
Ma'am, we've had cases, we've been reading about reports where people who've traveled from a foreign country have come back and have been wanting to test themselves for COVID-19, but they've been refused. Either they do not have symptoms and hence they've been refused, or they've not traveled from an affected country and hence they've been refused. Is that the right way to go about screening travelers from foreign countries, especially in a health emergency?
I think anyone with symptoms should be evaluated. If there is, so we know people are coming from many countries, but airports themselves are a source of transmission. So you may not have come from a country that is very badly affected, but you will have transited and been in contact with people who have come from many other places as well. So I think for anybody who is an incoming traveler looking at symptoms and then testing them, irrespective of which country they came from, is a good thing to do. I also think that we need to do syndromic surveillance. The influenza network is doing a proportion of that, but it is a proportion. I don't see why we can't expand that to severe cases, to less severe cases, and come to a point where we can do the kind of screening and testing that China and South Korea or Singapore have done, which is not risk-based testing, but testing for anybody who might potentially be infected. In fact, in Singapore, they were allowing doctors to order tests even if a person did not fit the case definition. And in a small study, over 10% of all the infections that they found was because the doctor had a suspicion and ordered the test.
Right, but ma'am, is that a criteria of not having enough testing capabilities? Do we not have enough testing centers or testing kits? Because that has been one question that has been raised time and again, saying that that could be one reason why the government is not testing. Or is it that the government feels that, considering we are still in the local transmission stage, we don't need to expand our testing criteria?
So I think the government is thinking about expanding testing. We've seen that they are now going to allow accredited laboratories to test. I think we will see testing expand greatly, and it is not a question of resources at this level. We've heard from the ICMR Director General that even the laboratories in the ICMR network are not functioning at capacity because they're getting very few samples to test at the moment. So I think we should be expanding the pool of people that we are testing rather than so in terms of laboratory capacity, if you look at private labs, we could expand testing 100-fold with no problems at all we need to be able to do real-time PCRs is to specify what the protocol is and provide those laboratories with the primers and probes. So it's in terms of laboratory capacity, this is doable. In terms of identifying patients and collecting samples from those patients, this is something where we really need to expand how we decide whom to test. As I said earlier, I think we should be moving well beyond travelers. Travelers from everywhere, if you want to do that, but it has been shown that traveler-based screening is not the perfect way to detect all infections that are imported. But I think we need to look to see about what's happening in communities. If we find that there is nothing, that's great. Unfortunately, I don't think that we will find that, but this time I'd be very happy if I'm wrong.
So these private laboratories, do they have enough capacities, or how much time will they need to scale up to come up at par and start doing the volumes that we're talking about?
So yesterday it was announced that accredited private laboratories that have national accreditation would be allowed to test. And I think this is a great move on the part of the government because it stresses the government system a lot less. When we share the workload, then there will be less work we won't be overwhelming the government system.
Countries like South Korea have made testing free of cost for every single individual, whether you have symptoms or you don't, and you want to be tested. Can India attempt something like that?
I think we should be thinking about providing much greater free testing. We could do it as a way of saying that if you have symptoms and you meet this case definition, or if your doctor thinks that you require testing, then testing will be done for free. And that would be great to do. I think there are a lot of people who are very worried, particularly if they have elderly individuals in their families or someone who's undergoing chemotherapy, has diabetes, has hypertension, etc., where even people who believe that they have come in contact with somebody who might be infected might want to get tested. In that case, I see no reason why they shouldn't get tested if they pay for it, because it's really for their own reassurance rather than to solve a public health problem. But in terms of where it affects public health, I think we should be thinking about making it free or discounted, greatly discounted.
Ma'am, as far as development of testing kits is concerned, certain companies have come forward and said they have those testing kits that can, expand the numbers, faster testing for more number of people, particularly like that of Roche. What's your assessment on these development, on these testing kits? And secondly, even Department of Biotechnology was working on diagnostic tools that would, help us screen large number of people at the same time. Where are we as far as that development of screening kits and screening tools is concerned?
So the Roche Cobas system that has been approved by the FDA for testing is something that a lot of Indian clinical laboratories already have. So it's just a question of buying the kits from Roche and running them on the machine. But to do that, we need permission to import, and that would require for Roche to apply to the Drug Controller General of India for permission to bring the kits into the country. Then the laboratories that already have the Cobas system could test. In terms of developing new diagnostics, there is work that is ongoing, but in order to do that work, You need access to both different kinds of reagents as well as samples from patients who have tested both positive and negative. And that is something that the Department of Biotechnology is working on. In terms of being able to test at the population level, uh, doing PCRs for patients is the first step, but we really should be thinking about transitioning to assays that allow us to assess exposure, which are antibody based tests, and DBT is working on those. Those usually take a few months to develop, and we will need well characterized samples from patients where we know what the outcomes have been to both develop and then validate those tests.
Right, but do we have enough samples to test these diagnostic kits at the laboratories? And how much more time before an indigenously developed diagnostic kit for COVID-19 comes up in the market?
So I understand that there are already India-developed screening kits available. There is a company in Hyderabad that is making kits. There's another one in Ahmedabad that has just had its kit made, and they are applying to DCGI for approval. Molbio in Delhi has a PCR kit that has already been sent to the National Institute of Virology for validation. So there are multiple manufacturers in the country that are making these kits and now want marketing authorization to be able to sell these kits in the market. In addition to that, multiple laboratories have, in terms of being able to do the testing as opposed to having commercially available kits, the primers and probes that are required were published by the CDC. They got some things a little bit wrong, and the WHO and other researchers around the world. The Chinese protocols are available to everybody. So in terms of kits, there are some that have been developed. In terms of testing protocols, there's a lot that's already available. It's a question of synthesis of primers and having the right probes to be able to get testing off the ground. In terms of samples to be able to validate these tests, that is important. But remember, when you're doing a PCR-based test, confirmation is relatively easy because you can amplify multiple parts of the genome and sequence the virus. So even if you don't have a positive control in your test, you can still get confirmation of the result by using another technique, which is sequencing.
Well, ma'am, everyone's been talking about flattening the curve, slowing the progression of the disease outbreak. But are we as a country doing enough? Considering the density of population, some people are working out of home, but if you step out right now, for the larger crowd, life is going on as usual. For many, work from home is not an opportunity or an option. So are we doing enough to, actually flatten the curve?
That is true. Wherever you have people in contact with each other, there is a risk of transmission of infection. So one infected person in a mix can transmit to a lot of other people. About between 30 and 60% are the estimates, closer towards the lower end. So the risk of acquiring infections anytime you're in a crowd, anytime you're spending prolonged periods of time with people are there. But we are constantly acquiring respiratory infections of various kinds, other infections of various kinds. As I said earlier, what we are trying to do with flattening the curve is trying to stretch out the time it takes for people to get infected. And it's important to remember that every action that you do can potentially help decrease that risk. We've seen a lot of discussion around washing your hands. Obviously, that helps. If you look at not touching your face, that helps. Opening a handle with a paper towel, wiping down a pole that you hold on the train before you hold it with a sanitizer would help. Now, is it possible when you're pressed up against each other to avoid having someone breathe in your face? You can't. But it's important to remember that there are things you can control and things you can't control. And wherever there is something that you have control over, do that. It's important also to remember that it is the younger people, the fitter people who are going around and traveling. So when these people come home and you have somebody who is more vulnerable to severe disease, that is where you have control of the precautions that you can potentially take. Take off your outside clothes, put them aside for washing. Make sure that you have a shower or bath when you come in, if there's enough water. But if not, at least change your clothes, wash your hands, wash your face before you go close to somebody who might be at risk of having severe disease if infected. So every action that we do that we can control that decreases risk of transmission is a good one. It will decrease risk for this coronavirus and it will decrease risk for other infections as well. That's important for us to remember. There are things, as I said, that you can't control. And then I think it's very important to not beat yourself up about it, to not get into a panic if you could not control the situation. If you did have somebody, let's say, cough in your face, everything that we do is a risk. And somebody coughing in your face is definitely a risk, but it's not your fault. You couldn't have done very much about it. So it's important, as I said, to stay aware, do what you can, limit interactions as much as possible. And if you can't limit those interactions, it's very important not to go into a negative spiral and feel guilty about these things. So right now it's not, and the Delhi government has notified 3 hotels as potential places in AeroCity where people could undergo quarantine if they can pay for it. But what actually worries me is I don't think our quarantine facilities are good enough. And there is a lot being said around how you must accept that this is for the public good and therefore put up with poor circumstances for the period of time it takes for you to be quarantined. And that is correct. But I also think that it is possible, if we decide to go for it on a war footing, to build better bathrooms for people. So it must be remembered that this is a virus that transmits through the respiratory tract and multiplies in the gut. We have currently no evidence that it is transmitted fecal-orally, but SARS certainly was. And one of the ways of transmission was because sanitation wasn't good. There was a toilet breakdown that led to a lot of people being infected. So when you put people in quarantine, the fact that you're putting people in quarantine when you might have an infected person there, and this is a respiratory infection, you are in fact increasing the level of risk that the group that is quarantined might potentially have. So that's through the respiratory route. If you can do something about preventing that by putting people so that they are housed at great distances apart instead of what we have seen, which is where the beds are actually quite close together for people who are being held there, as well as by improving the bathroom and toilet facilities, I think it would go a long way in helping people stay in quarantine. It's easy to say that if you've been told to stay in quarantine, stay there. But there is a lot of support that needs to be provided to people who are actually quarantined. And it should include reasonably decent conditions in which people are held.